So the previous speakers, the two speakers, Jane Mashingia, my colleague from the EAC, Asma from the North, have really done quite a wonderful job pointing out a number of things in terms of defining the concept and the good to do within the concept. So I will just go straight to some of the points, and in some slides I'll be picking some of the points so not to duplicate and therefore save time. The next slide, please. So I will start from the essence of economic integration. I work in the region where we are striving to have integration in all the walks of life of a human being. And the essence is to reduce costs for both consumers, producers, and to increase trade between the countries that are involved, which means when we talk about regulatory reliance, that should be the core of the intention of the reliance. And from here, I have a quote from Santiago, where I said, "A bridge is born of necessity, but if must establish its own identity, it should harmonize with its surroundings, and the design must transcend the pure local and transform the settings." My take from this point is that to be able to harmonize, to be able to recognize each other, there's a top-button approach that is basically the leaders, the boardroom, the white-collar people are looking at where the region wants to go. But at the same time, there's a demand side where you have the communities, the people, different levels of the supply chain having expectations. And my presentation will be focusing purely there, who is who in the ladder. But at the same time, in the end, what do we need to be done to work better in the regulatory reliance implementation? So allow me to proceed to the next slide, where I'll be talking a bit about EHP, and then I'll go back to the topic so that you know I speak for which organization and what they do. So the East Africa Health Platform is an apex body for non-state actors, looking at connecting the region for two major reasons. One, bringing the non-state actors, everybody who is not government, into a conversation, into a discussion, into a dialogue with the public sector when it comes to the common goal of one direction of the East Africa people, but looking at our health situation and the market side, the supply side, the demand side, to ensure that the voice of the non-state actors is heard. Our membership is across the 6 countries of the East Africa. And basically, we have the private hospitals, we have pharmaceutical operators, we have associations of such, civil society, faith-based organizations, and what we call the interest groups. These would be focusing basically on specific elements, maybe children, women, specific disease areas. These are all our members. We look into advocacy, constituency development, looking at issues of capacity, capability, and also we are interested in gathering evidence for our work so that our advocacy is informed to influence the change. So we are instigated by, our interest is instigated by the EAC Treaty, Articles 118 and 127 all the way to 29, where it talks about the people-centered integration and private-led. Our entry points are technical working groups within the EAC. That's where we're sitting, in, not in all of them yet, but our interest is to sit in those technical working groups so that we sit with the decision makers to make the decisions together, present the non-staters' voice within the process instead of waiting to complain. Our platform is a high and unique connect with the public sector in collaboration with the healthcare federations. But at the same time, I want to mention our unique point also is bringing the business and non-business organizations in one room. So this is a catch for us. So moving from that, the next slide, I don't want to use a lot of time. I listened to the 2 previous speakers. All this has been said, but I want to emphasize that working together, recognizing each other's standards and quality and processes. The mutual recognition point we're making is based on trust. That is one point. But also you must have a confidence in the other. But at the same time, there must be a common goal. And for the East Africa community, basically all partners to the East Africa Treaty, they have a common goal. Issues of trust and confidence are some of the factors that are bringing them together, us together, and therefore working towards maybe at a point having a regional regulation authority rather than having multiple, or working together but with a very clear goals. And here I want to say that the recognition is an option to routinely accept work and products of another regulatory authority, which is not an easy thing. Within integration, there are quite a number of questions. Although EAC is known to be one of the fastest growing economic bloc, but we still have issues around trust and around confidence in each other. And therefore, the processes later, I'll be talking about that there's a slow pace. But the comprehensive, okay, first of all, the relying authority, we have national authorities. Much as they come together, the specific authorities will remain responsible and accountable. But on the nature of the national regulatory authority. And of course, I want to make a point here that within a certain context and territory, there will be maybe different outcomes. But again, I want to talk about mutual recognition, looking at the market facilitation. If the EAC, we're talking around 170 million people, looking at it as a block, a market, then we're looking at mutual recognition and issues of reliance as one of the factors that may positively or negatively facilitate a market in terms of all the parties that are engaged. And these would be patients or healthcare providers, the national regulatory authority, but also the industry operators. These are key actors within that particular process. In terms of the rationale, which is the next slide, I'm looking at SDGs and universal health coverage, striving towards strong regulatory systems for medical products that are very central to ensure that there's a well-functioning health system. We cannot talk about functioning health systems when I have to enter into East Africa and do a multiple registration into different countries, but I'm going into the same market. And this is an important contributor to improving access and ultimately achieving UHC in the near future within our target line. I look at another issue that when I listened to other people speak, I want to pick a point that in order for a regulatory authority to come into an agreement with another or more than two, issues of capability are very important. And I think Jane alluded to that, that we have variations in terms of capacity in the level of development. And therefore, for EAC, it has taken a phased approach where we don't have 100% mutual recognition, but in terms of some elements, they have agreed to align specific roles to those who are capable in those particular expertise area. So what I'm emphasizing here is that the EAC has taken a partial harmonization where they use different capable regulatory authorities to be able to lead within the block. The next slide, please. So I'm picking some points that were not mentioned just to save time. So the EAC is one of the first REC in Africa to develop and implement the harmonized program. Jane has talked about it in 2012, but also the program does this through harmonization of regulatory requirements, guidelines, standards, and tools for the EAC national medicines regulatory authorities. Next slide. In terms of the structures for decisions that are made, the Sectoral Council on Health is the highest, but there are sectoral committees and then steering committees for various specific areas are there, but they are connected to NEPAD. There's a connection to WHO. And then I want to also mention the issue of the technical working groups, so that you know within the regulatory system, they are using the technical working groups to be able to align and decide on various matters or standards, quality, and all that. Next slide. So some of the key joint activities, they have aligned, agreed to work together, but with a specialization sort of approach. In terms of good manufacturing practices, the EAC is led by Uganda. In terms of information management systems, the EAC is led by Rwanda. In terms of medicines evaluation and registration, Tanzania takes lead. Quality management system, we have Kenya. And via the technical working groups, partner states have developed harmonized guidelines, requirements, standards for all these areas we have mentioned. In collaboration with WHO and the Swiss Agency for the therapeutic products, they began a joint dossier assessment in 2015, joint inspections for good manufacturing process, compliance, in 2015 that took place. So I will go straight to another slide talking about challenges. Maybe hello, next slide, please. Okay, we're here. Thank you. So in terms of the overarching challenge right now, someone may talk of COVID-19. For me, I look at it as a challenge because we cannot physically get together to do what the regulatory authorities had agreed. But at the same time, I think this is the right time to talk about this agenda, because it has really tested our systems and our ability to implement and function in any circumstance. So for me, COVID-19 is a challenge, but at the same time, an opportunity to reevaluate ourselves, see whether what we have set up is working, and therefore improve accordingly. Other challenges include the limited in varying capacities. Jane had talked about this in terms of infrastructure, the human resource, limited harmonization of regulatory affairs. So when you talk about Uganda, Tanzania, Kenya being way forward compared to Burundi, Rwanda, South Sudan, so these are some of the challenges that the EAC will have to grapple with. And already they have a plan to support national regulatory authorities to upgrade each of them before they can be able to actually realize the mutual recognition in full. Donor dependence is a huge issue. The EAC MRH is largely funded by donors, WHO, World Bank Group, Gates Foundation. Well, it's good for a starter, but the question is how ready, how capable, how able are we to be able to foot our own bills when it comes to this key goal. So this is one thing that we could push for, to ensure countries are able to allocate resources and ensure we have enough trained personnel to be able to run the agenda. Limited awareness and ownership among the stakeholders. There are still many stakeholders perceiving harmonization as a top-down initiative, which really this particular perception does not really support the agenda. You find the governments, the people sitting in boardrooms, the technical people at EAC, quite ready and understanding, trying to push, but when it comes back to the nationals, it takes a slower pace because of this particular ownership issue. And maybe the external parties, are pushing more, having a better understanding of the goal and benefits of this particular agenda. So ownership is a key issue I want to leave on the table. The absence of clear strategy for collaboration. There are documents written for this mutual recognition, which areas that will be implemented first and what follows. But at the same time, we lack a very detailed document on the strategy, how we are going to make it work. What are the timelines? What are the key indicators? What do we need to put in, both as local owners, meaning the states, the EAC itself that is coordinating, and how do we have an exit plan, like when we have donors now supporting us, for how long are we going to be able to invert the triangle to be able to get there and sustain actually what we put on the table, the agenda. Finally, as I conclude, I think regulatory reliance is a critical path to harmonization and a key factor to the achievement of UHC. But also, functionality of the regulatory reliance is highly dependent on the legal and policy frameworks. Do we have a good regional and national regulatory framework in terms of policies and laws that are going to support this working together process? Capacity of each NRA and awareness and political will of each party to be to the agreement. The EAC Treaty and Article 118 compels partners to state to cooperate on the health matters of the community. I think this is a good support, but it will have to be really quite supported by national laws and policies. The EAC Treaty compels to implement regulations, directives, and decisions. However, the treaty is not self-executing. Policies created at EAC require domestication. So countries will have to really be at the front of this to be able to domesticate each bit of the agreement to be able to implement with a good pace and with good resources to make it happen. Stakeholder engagement is still an issue, and I speak here for the non-state actors, meaning the private, for-profit, and non-profit. In this whole process, when do we go to a point of being key players in terms of the non-state actors also being part of the decisions that are being made, but also contributing to the resource pool to be able to make it happen? In the end, we sit on a table on different sides, meaning the governments are putting policies and laws, while the private sector, especially those who are in business, urging for a change of systems, change of modus operandi, to cut on time, to cut on cost, to cut on the procedures, so that if I want to bring in a certain medicine, I will not have to go to every entity, or even if when I bring it to the EAC, as it is right now, the joint team will look at the approval, but still the specific country or countries will have to go back and validate. So we still have issues of either trust or capacity that are still hindering, and therefore getting there is still quite a journey. So with that, I want to leave it on the table for any questions and further discussions and inputs. Thank you very much for listening.